Thank you, Madam Chair. Director McSwain, according to Northern Cheyenne tribal leaders we spent some time with, IHS owes over $2 million to those Northern Cheyenne members for health care received from non-IHS providers. Some of these tribal members get in trouble with bill collectors. They've got to put off paying other bills in order to pay health care costs that should be reimbursed by IHS. My question is, what is IHS doing to make reimbursements clear and understandable for the average patient who's juggling work, kids, and other responsibilities?
Thank you, Senator Daines. What we're doing on several fronts, and it's something that Dr. Rubido just mentioned, which is the education program that we've put in place. I know that we have a new acting director up in Billings who has really been doing some great things about orientation of the hospitals. She's a hospitals expert, and to really get out and talk to the providers. What we're finding out is people self-refer, and so we need to connect with the facilities that they're self-referring to, and ensure that they're being referred to them for payment, so we can ensure that they don't get caught outside of an authorization. Because if they're going into a facility, our contracts are actually, it's not referred to as a purchase referred care, has a set of requirements on referral, and a lot of it's just for maintaining continuity of care.
Do they track that number? Is that something as a metric that people look at?
This is one that we monitor closely, and through the business offices and the like.
Yeah, maybe for example, like with the Northern Cheyenne situation, if there's $2 million outstanding, who looks at that number, who reports it, and who's held accountable for it?
Each of the area offices across the country that begin to face these larger amounts sit down with the hospitals and actually go down through the actual claims that are being levied against the patients, because obviously we want to get in front of those and resolve them.
Yeah, it'd be helpful, I think, for us, too, because we've got a Billings office there. I think it's out of your Billings regional office. We could look at those numbers and track those with you to see, is that declining? Is that number going down every month?
Yes, so I made a note of it, and we'll
all right,
follow up.
I'd love to see that number. Yes. All right, okay. Great, thank you. Dr. Rubido, 2 weeks ago when you testified before the Senate Committee on Indian Affairs, we talked about the administrative costs at IHS. I know that in FY13, $6.5 million was spent on admin costs at our Billings area office, out of $18.5 million spent overall in the Billings area IHS. Well, I understand it's necessary to have some admin costs in any organization. Is this money being effectively spent? That's about 35% of the total spend there out of Billings. And how exactly does this money help get our services to our tribal members who need it?
Well, there's statistics out there that there's two sets of statistics, and what I'm finding is that there's confusion about the statistics that people are looking at. So we'll provide you with two pictures. One is the overall administrative costs for the Billings area, and that's about 11%. But if you look just at the area office is, the purpose of it is for administrative, to help the local service units. So I think that there have been some charts and graphs out there that I think there's been some overall misunderstanding. But when you're running a healthcare program, I know that everybody sees the doctor and thinks that's all that needs to happen, but you definitely need to have some administration. Overall for the Indian Health Service, it's at about 10 to 11%. And in the Billings area, overall, when you look at the whole area, it's only 11%. But the area office itself would have that higher proportion just because it's providing administrative functions to support the local service.
Do you all have a goal to try to continue to reduce your admin costs as % overall spend? Is that something you've set targets for to see reductions in that number?
We have worked on ways to reduce that number. The number will also reduce over time as more tribes contract and compact, but we've done things like reduce travel by half. We've reduced conference expenditures by 1/3, and we're always looking for ways to be more efficient and to save dollars.
Speaking of measurements, and I was struck by the testimony of Dr. Rubido of 39% increase, I believe, in IHS funding since 08, 53% with the President's budget versus 08. I see we're touting increases in spending. I want to talk a little about what are we doing in terms of measuring outcomes, in terms of what are we getting for the investments made in terms of improving health in Indian country. I was recently, our our staff was engaged with the Chairman Staffney of the Assiniboine and Sioux tribes of the Fort Peck Reservation. The average age of death for his tribal members over the last few years has been 51. As I get older, 51 sounds a lot younger. The Fort Peck Reservation is larger than the state of Delaware, yet has only 2 IHS clinics. And as Senator Tester mentioned, I hear the same thing. I probably hear more complaints about IHS than anything else I hear out in Indian country. The challenges are enormous, and the problem is made worse by these huge distances to get to both IHS and non-IHS facilities. Question, what are we doing to measure outcomes from IHS? I mean, I heard all about increased spending, more money, but what are we doing right now, and how are we measuring outcomes in terms of improving health in Indian country?
Well, we've actually done a lot over the past few years to improve and measure outcomes. We measure outcomes on the quality of care as how we're working, and we have so many examples of that when we do the Government and Performance and Results Act or GPRA indicators. We also have some data that should be available soon on how we measure the ultimate long-term outcomes like mortality and life expectancy. And you know, the numbers are getting better overall. If you look at the life expectancy at birth in 1972 to 1974, it was 63.6 years overall. Now for 2007, 2009, it's 73.7 years, so we've gained like 10 years overall. But it's clear that there are some areas where when you look at the specific tribal data, you can see that there's disparities even among tribes in terms of their life expectancy. And we absolutely want to continue to try to get that trend of improving life expectancy and reducing mortality in a number of areas. The Special Diabetes Program for Indians is the best example. It's funded to be evaluated. We've not only been able to show improved care, we've been able to show that the diabetes prevalence is slowing. It's not going up as fast as it was, and we're able to prevent diabetes and end-stage renal cases.
I'm out of time. One last follow-up, and then I'll yield my time. But I'd love to align our tribal leaders and chat with the IHS and get on the same page in terms of outcomes and measurement of quality of care. So that these are measures that the tribal leaders will say, yep, that's the right way to measure the quality of care versus what's coming out of our centralized command and control here in Washington, D.C. Bureaucracies. So,
completely agree with you on that, and that's what we're trying to do with we're encouraging the CEOs at the local facilities to meet regularly with the tribes and understand tribal priorities and develop those measures together.
Because ultimately that's the customer. That's who we're trying to help.
Love to work with you on that.
Thank you.